Namaskar. Very good morning to all. Please welcome all our guests for the day, Professor Y.K. Gupta, National Scientific Coordinator and Chairperson, Signal Review Panel, PVPI IPC. Dr. Kiran Kumar Karlapu, Deputy Secretary, Drug Regulation, Ministry of Health and Family Welfare, Government of India. Dr. Rubina Bose, Deputy Drugs Controller General of India, Central Drugs Standard Control Organization, Government of India. Dr. Madhur Gupta, Technical Officer, WHO Country, Office of India, who has joined us virtually, and Dr. Rajiv Singh Raghuvanshi, Secretary cum Scientific Director, Indian Pharmacopoeia Commission, Ghaziabad. Indian Pharmacopoeia Commission is delighted and honored to host the celebration of Second National Pharmacovigilance Week commencing from 17th September 2022 to 23rd September 2022 at IPC. I am privileged to inform you that National Pharmacovigilance Week is being celebrated throughout the nation. We welcome all the distinguished dignitaries, higher officials of the ministries, national delegates, IPC and PVPI staff, and all the stakeholders attending this inauguration ceremony physically and virtually. I now request Dr. Rajiv Singh Raghuvanshi to welcome National Scientific Coordinator and Chairperson, Professor Y.K. Gupta ji, with a flower bouquet. A very warm welcome to you, sir. Sir, please welcome Deputy Secretary, Drug Regulation, Ministry of Health and Family Welfare, Government of India, Dr. Kiran Kumar Karlapu ji, with a flower bouquet. Warm welcome you, sir. Sir, please welcome Deputy Drugs Controller General of India, Dr. Rubina Bose, with a flower bouquet. Sir, please welcome Dr. Madhur Gupta, who has joined us virtually. A very warm welcome you, ma'am. Thank you, sir. Thank you all. It is an honor to invite guests and dignitaries on the dais to light the ceremonial lamp and inaugurate the proceeding of the day. I request our volunteers to kindly escort the guest for the lamp lighting. इधर से आएंगे सर Thank you so much. Thank you all. Thank you, sir. Now, it's time to formally commence the event. We would like to start with the national anthem. I request everyone, physically or virtually, to please rise up for the national anthem.
भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल विंध्य हिमाचल यमुना गंगा उच्छल जलधि तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय
Thank you, everyone. सर लोग आए इनको बैठाओ. I request all dignitaries to kindly release the annual report and newsletter of PVPI 2022. Thank you, everyone. Now I request Secretary cum Scientific Director, Indian Pharmacopoeia Commission, Dr. Rajiv Singh Raghuvanshi ji, to deliver the welcome address.
Thank you, Madhu. Respected Dr. Y.K. Gupta, Dr. Rubina Bose, Deputy Secretary Kiran Karlapuji, virtually attending Dr. Umila Thatte, Dr. Madhur Gupta, colleagues, friends, and all the delegates attending physically or virtually this morning, this important event for inauguration of National Pharmacovigilance Week. I welcome all of you to this inaugural gathering of Second National Pharmacovigilance Week. And at the onset, I want to congratulate all of you for being part of this important event. And also want to thank all of you for taking time on Saturday to come and join this important event. All of us know that we started National Pharmacovigilance Week from last year, and this is the second week we are celebrating. And the purpose of celebrating National Pharmacovigilance Week, in the beginning we thought that this would bring this whole program into center stage at the national scene and beyond. And I'm very happy to say that the first one which we celebrated last year in 2021, it was a grand success. And you will see in my subsequent some of the data which I'll show you that it has created a lot of impact when we did it last year. And this year, the way we are getting the feedback and signals from the system looks like it is going to be bigger than what we did last time. And when I say bigger, I'm more talking from the point of view of making it more broad based. So this year we see involvement of people from places which was not active last year when we celebrated National Pharmacovigilance Week. And that's probably the reason why we did that. And I'm sure going forward, this is going to grow exponentially and become one of the important tools and model for popularizing pharmacovigilance program of India in this country and beyond. In last so many years, pharmacovigilance and material-vigilance, Hemo vigilance, all three components of vigilance program have grown significantly since we started about 12 years ago. Today, I'm very happy to say that we have more than 600 centers enrolled as AMC and spread across all the states, except for I think 2 states at this point of time in the country, where we have more than one center operating and actively contributing to the program. On the similar lines, if I talk of material vigilance, we are close to 300 centers operating in the country today, actively contributing to the material vigilance program and the reportings which we get from there. So between both these programs, Vigilance and Pharmacovigilance, we are about to hit 1,000 centers, and which is going to be a big milestone for us. And I'm sure next couple of months we will hit, because the number of LOIs which we currently have for both these programs, that takes us beyond 1,000 number, which is going to be a big boost and motivating factor for people who are actually involved in these vigilance programs. The reportings also have increased significantly from where we started. And if I see the way things are moving this year, looks like we will double the reporting as compared to what we did last time. Last time we were around 70,000 reportings last calendar year. And this calendar year looks like we would be crossing 150,000 reportings as a contribution into the WHO database, which is again a very big achievement for us. Mere crossing the number of 100,000, which is a psychologically very motivating factor for all of us. And we would be way beyond that 100,000 number when it comes to the reporting. And the best part of this whole story, which is unfolding, is that we have now started getting people from different areas approaching us on their own to participate in pharmacovigilance program. Some of the areas which need much more focus, and maybe since we are operating at the national level and we are more at the macro level, we might be missing some focused areas which need pharmacovigilance intervention. And one such example is one of the faculty from Lady Hardinge Medical College, Delhi, in the dental domain, Dr. Pravesh Mehra, he actually approached us through ministry that he is interested in starting a program in pharmacovigilance and material area, because he feels that lot is required in terms of vigilance intervention when it comes to dental domain, which is being currently missed, not being addressed, because there are so many medical devices and tools and techniques used in dental domain which need this kind of intervention, because there are lots of misses which happen which goes unreported, and the whole dental domain needs a focused intervention. Similarly, if I see, this morning I was looking at the agenda of one of our partners, I think University College of Medical Sciences in Delhi, Dr. Vandana Roy. So I was looking at their agenda, and I was so happy to see that they are actually organizing Nukkad Nataks to make pharmacovigilance program popular among the common masses. And all out of the 7 days, I think 4 or 5 days, they are actually doing Nukkad Natak at different communities in and around Delhi, not in the medical college, but in the societies where they stay. And so they have created a team of their internal people who are doing this Nukkad Natak. And if some of you remember, that was first thing which I had requested this team also to start doing Nukkad Natak when we were actually planning in the beginning when I had joined, because that is a so impactful communication mode that it just leaves mark on your uh, system that yes, there is something. So I'm just putting some of these examples which tells us that the PVPI program is actually now becoming broad-based. It is not within the four walls of IPC or AMCs. It is actually moving beyond, which is the one of the most important and motivating factors for people who are involved in this program and want to make it successful. About a year back, another data point which tells us a positive movement in this. If I see the centers which are actually reporting today, about a year back, or maybe a little more than that, there were 3 centers in the country who were reporting more than 1,000 reports in a year. There were only 3 centers. I think one was PGI Chandigarh, another was JSS Mysore, and there was one more, I think Kerala or Chennai somewhere, right? Or maybe Ahmedabad. So there were only 3 centers. And I still remember the highest number of reporting from PGI was 1,200, around 1,200 something. And I was looking at the data this month, and it is so heartening to see that today we have 13 centers in the country who are reporting more than 1,000 in a year. So that 3 has actually grown to 13. And another good and very encouraging point is that 1,200 reporting maximum has actually this year going to be more than 3,000 reporting by that center, which is again PGI. So the way it is moving, and for last 8 months, 8.5 months reporting which we are getting, if I extrapolate that, that goes beyond 3,000. So these are some of the signals in the system which tells us that whatever we are doing in the right direction. The outcome is positive. The efforts which the team is putting is actually bearing fruits, and very happy to see all these data and number in the system. This program also is beyond India. If you see pharmacovigilance program of India today and the way the team has operated, the recognition is now beyond India also. If I tell you a couple of points which can tell us that the growth is actually moving beyond India is our WHO NCC, and not only WHO NCC being a collaboration, but the work which is happening under that program, it is being recognized by WHO. Lots of things which we are doing in India is being taken up by WHO as a model to use among their programs in other countries outside India. If I come to the CERN, that group of 11 countries around India, there I'm happy to say that I'm actually chairing that working group 3, which is on vigilance. Our program, our basically the experience and the learnings of Indian program is being used for capacity building in all these countries directly by us or through WHO. A couple of weeks back, we have been also included in the capacity building program, which is run by Ministry of External Affairs for other countries. Whosoever needs support from us through the Ministry of External Affairs program, they will facilitate, the ministry will facilitate, and we will actually be conducting those capacity building programs in those countries. So just to say that also the one very successful program sometime back we did on training the CERN countries, I think, on traditional medicine pharmacovigilance. That was on request of WHO traditional medicine pharmacovigilance program, which is being led by Dr. Kim here, who works from Delhi, but actually active in the CERN countries. So these are some of the examples which shows that the reach is actually increasing day by day. If I see some very important or good examples on the ground where the direct impact on the public can be seen, I can quote 2 programs where IPC and the pharmacovigilance program of India is an active participant. Is one, the current one which is ongoing is on miltefosine, where Dr. Madhur is also involved very actively, WHO is involved, our healthcare system in the country is involved, where the ocular issues coming out of miltefosine treatment for leishmaniasis is actually being monitored now, because it was observed that that it may be the side effect of miltefosine treatment. So that has that is actually being now taken as a structured program, and more studies are being done, and IPC is actively involved in that. Similarly, if you see sodium valproate, we had run a program sometime back where questionnaire-based survey was conducted to see the impact of this particular drug on childbearing age women. And that model has been now taken up by WHO, and WHO is going to use the same model in other different countries for the same purpose. So these are some of the examples which tells us that a lot is happening and we are moving in the right direction with respect to the contribution, with respect to the growth, with respect to the impact on the public health. So looks like this whole story is unfolding at this point in time. We are at an inflection point, and we have to start planning and for next couple of years and beyond, we have to see that how do we manage this program, because the way things are growing in the country and beyond, we will have to plan in a big way to tackle the work which is I can foresee that what's coming. So that is one area where this team has to uh, work very diligently and plan very strategically to handle. And here comes, it's just not possible that we go on increasing manpower and the work will be done. We'll have to bring technology here and put some efforts and intervention to develop technological interventions which can help us run this program and grow this program beyond what we are doing today, which is mainly manual collection of the reports and also the ICSR's analysis. So that is one area where the leadership has to certainly look into. Also, I have been telling this on different platforms and forums that one area where we still need to do a beginning, if I can say, is to bring in the common people into the program. Today, whatever is happening, more than 95% or maybe 99% of it is happening through the, the trained professionals who are practicing pharmacovigilance professionals in colleges, in medical colleges, in hospitals. But the common public is still, for me, untouched with this pharmacovigilance directly. And that is one area where I would need support from all of you to wear a different hat, not a hat of a professional, but a hat of a common man, and talk to common people in this country as common person and make them understand about this. And that would be if the day that starts happening and the day common person, common people start reporting on their own, that is the day when probably the real success from this program will come. So that is one area where I need support from all of you, wearing a different hat of a common person and doing this noble job. I'm sure wherever we have reached today from where we started, person like Dr. Gupta, who is sitting beside me, he was one of the people who actually started this program in this country. And when he sees it today, I'm sure he would be very happy to see where we have reached from where we started. And I can ensure, sir, that this will go on like this. And I'm sure you will be supporting us as you have been in the past. And at the end, the way I see this growing and the way it has actually come, only one couplet comes in my mind, written by Janab Said Udhianvi, that मैं अकेला ही चला था जाने मंजिल मगर लोग साथ आते गए और कारवां बनता गया. So PVPI is actually the same story which is unfolding. We started maybe from one center in AIMS, sir, right? And today we, as I said, we are actually between the two programs, we are going to 1,000 centers. So with this, and again congratulating and welcoming all of you today on this important and very um, very important day for this program. Again, thank you all of you and all the best for people who are involved in this program and taking it forward. Thanks a lot.
Thank you so much, sir. Thank you so much for your words, kind words, expectations, and your explaining the plannings. So, with this word, I would like to invite Dr. Jaiprakash, Officer in Charge PVPI, for PVPI update.
Thank you, Madhu. Good morning, everyone. Respected dignitaries and all the participants. It gives me immense pleasure to update you about the Pharmacovigilance Program of India, and we are encouraged with the words of the Secretary cum Scientific Director IPC to take this program forward. So I will be briefing you about the data which the Pharmacovigilance Program of India has collected and what are other things to be done in future as well. So I will start with a brief introduction to the Pharmacovigilance Program of India. What is the global scenario of pharmacovigilance? Update on Hemo Vigilance Program of India, update on Material Vigilance Program of India, etc. So may I have the next slide, please? Next. If you look at this slide, you will see that Pharmacovigilance Program of India was launched in the month of July from All India Institute of Medical Sciences, New Delhi, and I am also the witness that a 2 days workshop was organized by Professor Y.K. Gupta sir at that point of time to operationalize this program, and involvement of the Central Drugs Standard Control Organization was also there. So, sir, we are very grateful to you that the program got lot of momentum under your guidance and leadership, and we are not only getting the support for the Pvpi activities, but also for other activities of the IPC, and we look forward for the similar support in future as well. And so after 2010, this program was recasted by an order from the Ministry of Health and Family Welfare, Government of India, on 15th of April 2011, and the National Coordination Center got shifted from All India Institute of Medical Sciences to the IPC. The Hemovigilance Program of India is also under the ambit of the Pharmacovigilance Program of India, and this program was launched in the country on 10th of December 2012. Then, to look into the safety of the medical devices, MVPI was launched on 6th of July 2015. And the National Coordination Center for MVPI is also located at Indian Pharmacopoeia Commission, Ghaziabad. Now I come to the global scenario of the pharmacovigilance. Next slide, please. If we look globally, then as on date, there are 153 full members and 22 associate members who are enrolled under the WHO program for international drug monitoring. And it was in 1997, to the best of my knowledge, that Professor S.K. Gupta, the then head of the department at All India Institute of Medical Sciences, made the efforts to get the membership of the WHO program for international drug monitoring, and which was then taken forward by Professor Y.K. Gupta sir under his leadership. And India became full member of WHO PIDM in 1998. Later on, based on the contributions done by the Pharmacovigilance Program of India, World Health Organization bestowed Pvpi as the WHO Collaborating Center for Pharmacovigilance in Public Health Programs and Regulatory Services since 2017, and after completing a tenure of 4 years, it was redesignated for another term of 4 years. And we are sure that in the time to come, we will continue to maintain the same rigor, and we will continue to work towards maintaining the membership as a WHO collaborating center in future also, and to spread the network of the Pharmacovigilance Program of India. Let me touch upon each of the elements of the Pharmacovigilance Program of India one by one. Next slide. Please move. So, the Hemo Vigilance Program of India, which tracks, collates, collects, analyzes the adverse drug reactions due to the blood product, and the transfusion medicines, is the part of the Pvpi, and National Coordination Center is located at National Institute of Biologicals at Noida. This program is also become the mandate of the National Institute of Biologicals since December 2014, and there are the Hemovigil and Donor Vigil software in place, and presently the reporting to this program is voluntary in nature. And this program also has the national and international linkages with World Health Organization, with the Royal Government of Bhutan, and is a part of the International Hemovigilance Network in India, International Hemovigilance Network since 2014. The Hvpi is also coming out with many research publications. Next slide. And the number of the blood centers have been enhanced to a greater extent, and as on date, there are 1,333 blood centers who are sending the data to the National Institute of Biologicals. So the data is received from the donors, the data is received from the recipients, and they have also organized 76 continuing medical education programs and workshops, and have trained more than 15,000 participants in the past. 36 national and international publications have also come out, and the concept of hemovigilance nurse has also been implemented through the hemovigilance program system at PGI Chandigarh. And nowadays, 112 NABH blood centers, they are also enrolled under the Hemovigilance Program of India, and they have the guidance document for reporting of the transfusion medicines reactions, and they also have the softwares, and the analytical data is continuously being monitored by them. Next slide. Recently, they have also conducted a national conference on hemovigilance on 9th and 10th of December 2021, and many other events have also been organized, and the events were well attended by the participants. Next slide. They also are carrying out the research studies on the severity grading tools, and these studies are likely to be completed shortly. Coming to next slide, please. Coming to the safety regulations of medical devices in India, you will be knowing that the Ministry of Health and Family Welfare, Government of India, notified medical device rules in 2017 on 31st of January 2017, and these rules became effective from 1st of January 2018. These rules have the provisions for reporting of the adverse events due to medical devices and the post-marketing surveillance studies which need to be conducted on medical devices. So the seventh schedule specifies the post-marketing clinical investigations of medical devices as well. And if you look at the MVPI expansion and the structure, you can see that as on date, there are 293 medical device adverse event monitoring centers across the country, and these centers have been expanded in a phase-wise manner. Next slide. This slide shows the reporting trend of the medical device adverse events, and we can see from this slide that there is an increasing trend of reporting of medical device related adverse event, and till August 2022 the program has received more than 10,000 medical device adverse event report in the MVPI database, but there is a need still to put all this data into our own software. Next slide. The recommendations and alerts which have been issued to the stakeholders and where the action has been taken is mentioned in this slide, and 12 recommendations have been forwarded to the Central Drugs Standard Control Organization, and 22 advisory have been issued by the medical device by the MVPI, and action is being taken by the Central Drugs Standard Control Organization. Coming to the Pharmacovigilance program of India, this program has also been expanded, and as on date, there are 606 adverse drug reaction monitoring centers across the country. Next slide, and these centers have been expanded in a phase-wise manner. Next slide. As you all be knowing that the adverse drug reaction monitoring centers are the backbone of the program, and Pvpi is in the continuous process of inviting the enrollment form to become the new AMCs under the Pharmacovigilance program of India. So National Coordination Center seeks the letter of intent or the enrollment form, then they are examined here properly, and the approval is given by the competent authority, and after approval the communication is sent to newly approved ADR monitoring center, and technical support is provided to these newly enrolled centers in terms of providing them the standard operating procedures, the financial guidelines, the induction training programs, the continuing medical education programs to be conducted, and based on their performance, if their performance is found to be excellent, then these AMCs are also designated as the regional training and resource centers under the Pvpi. And today we have 12 regional training centers under the ambit of the Pharmacovigilance program of India. Coming to different channels of reporting of adverse events to the Pvpi. So we have ADR Pvpi mobile application. This application is freely downloadable from the Google Play Store. And we also have the Pvpi toll free number 1800 This toll free number remains operational for all 5 days since 9 o'clock in the morning till 5:30 in the evening from Monday to Friday. And there are hard copy of the suspected ADR reporting form, and these ADR reporting form are the source document for the Pvpi. These are maintained at the level of the AMCs, and this form is also available in newly launched National Formulary of India 2021 and is also there on the website of Indian Pharmacopoeia Commission as well as on the website of Central Drugs Standard Control Organization. Next slide. Coming to the data flow under Pvpi. So IPC is the National Coordination Center to operationalize this program. There are AMCs under it. Then there are regional training centers and user ID and passwords are provided to all the AMCs. So the data is entered online through the VigiFlow software of the WHO, and this data is handled in a confidential manner. So the patients or their relatives, the healthcare professionals, pharmaceutical industry, everyone can report to the Pvpi, and there are different committees under the Pvpi which help the IPC and ultimately come out with the meaningful information in the form of these signals. Next slide. This slide shows that we are also connected with the national health programs of the country, and there is active collaboration with these national health programs. Next slide. If you look at the reporting status, it is continuously increasing and more than 75,000 ICSRs are there as on date in the Pvpi database. And today we are the 9th largest reporter of ICSRs to the WHO UMC, and there are more than 6 lakhs of the ICSRs on behalf of the Pvpi. Next slide. We are continuously getting the reports on the toll-free helpline number also, and this is also increasing. Next slide. Then we have also conducted the training programs on continuous basis, and a voluminous response received last year after initiation of the National Pharmacovigilance Week. And Pvpi has recommended many safety signals and alert for implementation by the through the Central Drugs Standard Control Organization, and 11 signals have been identified by the Pvpi. And if you look at the next slide, you can see that ultimately the impact is seen and PIL changes. You can see how does it look like the PIL change for inclusion of Stevens-Johnson syndrome as the ADR in the PIL of the lamotrigine. So this has been implemented by the Torrent. So this is one of the representative examples. Similarly for ofloxacin. Next slide. And this is an impressive slide that among all other countries' data, we are on very good scale in the quality of the reports of the reports generated from India. So this has been provided by the World Health Organization, and this blue line clearly shows that the quality of ICSRs from India is relatively higher as compared to other countries of the world. Next slide. And this slide shows the overall ranking. We stand at the moment on the 9th rank in the reporting. Next slide. And the PVPI recommendations are also published continuously in the WHO Pharmaceuticals newsletter. Next slide. And we are coming continuously with the resource materials of PVPI, such as last year we released 10 years highlights of the achievements of the PVPI. And we are also publishing the annual performance report online as well as in the hard copy as well as the quarterly newsletters from PVPI. Next slide. Public outreach is also there, and more than 46,000 training, 4,600 training programs and sensitization programs have been conducted by PVPI and trained more than 2,25,000 healthcare professionals. And on demand, we are sending the poster and other resource materials to the AMCs. Next slide. And we also participated in the social media campaign to create the awareness about the Med Safety Week on invitation from WHO Uppsala Monitoring Center at Sweden. And we get a voluminous response and appreciation from the WHO UMC. And this slide shows the glimpse of the first National Pharmacovigilance Week celebration, and in total about 398 awareness programs and sensitization programs were conducted, and more than 33,000 participants took part in that National Pharmacovigilance Week. IPC is continuously organizing the skill development programs for different type of the participants, and this is a quarterly program, and last skill development program we just finished yesterday. It was 5 days virtual skill development program, and more than 130 registered participants were there. And the next program is due in November. So you are requested to encourage your colleagues and friends to participate in future programs of the skill development. And sir, one more idea is coming to my mind, that in the time to come, one day the PVPI should go to the height that it should become a separate National Pharmacovigilance Commission. So I request the ministry officials to take this forward, and to our secretary cum scientific director, that two ideas, like there should also be a World Pharmacopoeia Day to create the awareness about the use of the pharmacopoeias at the world level, and to set up one day a National Pharmacovigilance Commission. So with this, I come to the end of my presentation, and I thank you all for your attentive listening. Thank you very much.
Thank you, sir. Thank you for the update. Dear all, I am very happy to inform you that Dr. Montu M. Patel, President Pharmacy Council of India, has joined us. I request Dr. Rajiv to kindly welcome Dr. Montu M. Patelji with a flower bouquet. Welcome you, sir. Thank you. Thank you, sir. May I now invite Professor Y.K. Gupta, National Scientific Advisor, PVPI, to address the gathering.
Namaskar to everybody and good morning to all. And my special thanks and appreciation to Dr. Rajiv Singh Raghuvanshi ji, Secretary cum Scientific Director of this institute, जिन्होंने शुरू में कहा बहुत ही अच्छा, मैं अकेला ही चला था जानिब के मंजिल, मगर लोग साथ आते गए और कारवां बनता गया. So I am very happy and satisfied that ये जो कारवां बना है इसके सारथी डॉक्टर राजीव. और जब ऐसा सारथी किसी कारवां को मिले तो मुझे नहीं लगता कि इसमें कोई शक है कि यू विल बी वन ऑफ द टॉप फार्माकोविजिलेंस प्रोग्राम इन द वर्ल्ड. सो आई कॉन्ग्रेचुलेट एंड कॉम्प्लीमेंट डॉक्टर राजीव. और जब कोई रथ चलता है, जब सारथी चलाता है तो रथ के साथ में कुछ पहिए होते हैं. सो आई कॉन्ग्रेचुलेट Dr. Jayaprakash, Dr. Kalai Selvan, and all the members of the pharmacovigilance team, not only in IPC, but in the entire country, who are making this program a great success. When we started this program in 2010 at AIMS, I will just like to give a historic perspective to you so that you can feel pride in it. उस समय एक हमारी मीटिंग हुई थी जिसमें कि उपसला मॉनिटरिंग सेंटर के जो टॉप ऑफिशियल्स थे वो एम्स में आके हमारे पास डिस्कशन करने के लिए. डॉक्टर जीएन सिंह भी थे वहां पे, डॉक्टर दूसरे सिंह साहब भी थे, सुरेंद्र सिंह जी. हमारा वहां पे जो डिस्कशन का पॉइंट था कि उपसला मॉनिटरिंग सेंटर वाज चार्जिंग $10,000 टू यूज देयर प्रोग्राम, to lend their program so that we can upload our reports on them. And हमारे पास $10,000 नहीं थे. मिनिस्ट्री ने कहा कि ये तो हम अभी सोचेंगे. My argument with them was, हमारा तुम adverse reaction का डेटा ले रहे हो और हम ही से पैसा भी ले रहे हो. I told this in very clear term. ये this is the same situation कि अंग्रेज लोग हमसे हमारा कपास लेके हमको ही 10 दाम पे हम ही को कपड़े बेचते थे. हमने कहा ये नहीं होगा. तो उन्होंने कहा आपका डेटा है कहाँ? हमने उनसे कहा कि हमारा डेटा अभी नहीं है, लेकिन अगर 5 साल में हमारा इतना बड़ा डेटा हो जाएगा तो आप क्या करेंगे? रिजल्ट वहां पे उन्होंने माना उसको एंड दे एग्रीड टू गिव दिस अगेन कि हम 2 साल के बाद असेस करेंगे, 2 साल के लिए फ्री देंगे. नाउ द सिचुएशन इज दैट आवर डेटा इज सो स्ट्रॉन्ग that they will pay $100,000 to us to get the information. अगर हम bargain करें तो. We are so strong now. And the value of data, now the country is realizing, the whole world is realizing कि value of data कितना important है. There was a time, and I will just give you another example, when Dr. Ghulam Nabi Azad called me at his home because there was a parliament question. और उन्होंने कहा कि ये होता क्या है फार्माकोविजिलेंस, ये एडवर्स रिएक्शन क्या होती है. तो रात के 8 बजे से लेके रात के 11 बजे तक उन्होंने डिनर के टाइम पे समझा और फिर उन्होंने कहा अगर ऐसा है तो हम क्यों नहीं करते इसको. हमने कहा पैसे ही नहीं दिया आपने. एंड दैट वाज द टाइम विच आई से ऑलवेज कन्वर्ट द एडवर्सरी इनटू अपॉर्चुनिटी. वो हमारे पास मुसीबत आई, हमने उसको अपॉर्चुनिटी में कन्वर्ट किया. and then he gave whatever money we asked for pharmacovigilance program. That was the time जब आयरन गरम था तो हमने डॉक्टर रंजीत राय चौधरी को भी कन्विंस किया when he was a member of MCI, और उन्होंने हर मेडिकल कॉलेज में फार्माकोविजिलेंस की यूनिट को कंपल्सरी कर दिया. And now with the effort of Rajiv and with his team, this pharmacovigilance has expanded to 606 centers, which is, we feel pride that this is the biggest program in the world of pharmacovigilance. So we are the reason to pat our back ourselves. हमारे कई बार हम तारीफ करते हैं उपसला की, WHO की, इधर की, हम अपनी तारीफ करने में कुछ कमजोर होते हैं. तो आई थिंक लेट अस क्लैप फॉर आवर ओन सेल्फ. इससे इससे बड़ा कोई मतलब इस प्रोग्राम में शक्ति नहीं मिल सकती when Montu Bhai Patelji is here, because the entire pharmacy council is now with this program. जी मेडिकल काउंसिल भी अगर यहाँ पे होती रिप्रेजेंटेटिव तो बहुत ही अच्छा होता, लेकिन अगर हमारी फार्मेसी काउंसिल, और मंटू भाई जी को भी पता है कि फार्मेसी काउंसिल के लोग, फार्मेसी प्रोफेशन के लोग, फार्म डी, एम फार्म, यही लोग दुनिया भर में सबसे टॉप हैं फार्मेसी, ये फार्माको विजिलेंस प्रोग्राम चलाने में. हमें दो तीन चीजें देखनी है अब, कि हमने डेटा तो हमने बनाया, हमने कलेक्ट किया. हमारा अचीवमेंट था कि जब हमने शुरू में सेंटर शुरू किए 10, तो हमारा कुल मिला के 2000-3000 फार्मों को के डेटा आता था. हम कहते थे ये क्या डेटा है, टिप ऑफ द आइसबर्ग, जो हम दिखाते थे कि ये टिप ऑफ द आइसबर्ग है और बाकी सारा तो नीचे है. अब वो टिप थोड़ी सी और ऊपर आई, लेकिन अभी भी आइसबर्ग हमारा नीचे बहुत है. दूसरी चीज, when we have a huge data, there are two things. Huge data can be a noise, पता ही नहीं लग रहा कान में घूम क्या हो रहा है, noise ही noise है. And or we are able to convert this noise into music. Music means meaningful information, and that is what we are trying to do here, from signal detection and identifying the the advisories. And I am very happy कि हमारा नॉइज से डेटा क्लीनिंग करके डेटा की इंफॉर्मेशन करने के बाद वी ब्रिंग आउट दिस न्यूज लेटर. एंड आई विल जस्ट अगेन ए मैटर ऑफ प्राइड, मंटू भाई जी खास तौर से आप भी ध्यान दें कि ये न्यूज लेटर इज नॉट ए न्यूज लेटर विच गोज इनटू वेस्ट. 90% न्यूज लेटर को हम देखते हैं, पढ़ते हैं, और उसके बाद में वो 10 रुपए किलो या आजकल 18 रुपए किलो रद्दी में चला जाता है. This newsletter I appreciated in just 3 days back, release of national list of essential medicine in front of minister and all those media, that when we prepare national list of essential medicine, important criteria for deletion of drug, हम पहले हमने जो लिखा कि हम जो डॉक्यूमेंट्स कंसल्ट करते हैं, the first document we consult is newsletter of PVPI. एक टाइम था जब हमारे पास हम सारी एडवर्स रिएक्शन को, किस दवाई को हटाएं, किस दवाई में क्या करें, हमारे पास कोई डेटा ही नहीं होता था. चाहे हम निमोसिलिड हो, चाहे हम कोई भी ड्रग हो, चाहे बैन करना है तो वो इंटरनेशनल डेटा पे करते थे, हमारा डेटा में कोई होता ही नहीं था. और अक्सर सवाल होता था कि आपके यहाँ डेटा नहीं है, इसका मतलब क्या आपकी जनता इतनी तगड़ी है कि उसको कोई एडवर्स रिएक्शन होता ही नहीं है. So now we depend lot on this newsletter. And another matter of pride we all have, that the material in this newsletter is quoted by WHO, and they are also dependent on this. तो ये जो documents हैं, जब इतना important document हो गया, तो हमारी responsibility होती है कि we give in this information which is absolutely accurate, correct, and nobody can raise question. इसीलिए जब हम यहाँ पे डिस्कस करते हैं सिग्नल रिव्यू पैनल में, एक सिग्नल रिव्यू के लिए we entire spend whole day, so that nothing can go wrong in this, because this information is so crucial. कई बार the question which is raised by secretary and minister कि हमारे पास 600 centers हैं, and then पहले पूछते थे so what, so what. This is the question we have to answer. अरे भाई so what का आंसर अब हमको मिल गया. हमने इतने सेंटर बनाए, पहले फार्माको विजिलेंस प्रोग्राम डॉक्टरों को नहीं पता होता था, अब आम जनता को भी फार्माको विजिलेंस का नाम एटलीस्ट पता है. Now the next question is what next? और what next का जो आज I was so happy when राजीव जी said that हमारा ultimate objective है to reach, we have reached from all the medical colleges to secondary hospital, and the objective is to reach and penetrate to PHCs and to penetrate to general population or public, so that they also know कि ये दवाई का अगर एडवर्स रिएक्शन होता है तो कहाँ और कैसे रिपोर्ट करें. That is our objective. Now the next question is, which अभी पूछ रहे हैं, पूछा जाएगा, and this is what exactly I reported on just 3 days back, and you may read in the newspaper, is what more? और ये जवाब दिया जैसे जेपी ने और डॉक्टर राजीव ने, व्हाट मोर. इसके बाद हमें ये देखना है, एंड ऑल ऑफ यू हैव टू अप्लाई माइंड, कि इसका हमारे पास बैरोमीटर या इसका मापदंड क्या है जिससे कि हम कह सकें यस दिस प्रोग्राम इज सो यूजफुल, सो सक्सेसफुल. नंबर वन, have you or we should do the analysis, some of those who are listening should do analysis, how many deaths have been prevented by this program. कि एडवर्स रिएक्शन से हमारे कंट्री में, हम अभी भी स्लाइड दिखा रहे हैं अपने लेक्चर्स में कि इतनी यूएसए में एडवर्स रिएक्शन से इतनी डेथ होती है. अरे उस स्लाइड को बंद करो. क्रिएटेड डेटा के हिंदुस्तान में एडवर्स रिएक्शन से कितनी डेथ हुई, और फार्माकोविजिलेंस प्रोग्राम के आने के बाद में एडवर्स रिएक्शन से इतनी पॉसिबल डेथ प्रिवेंट हुई. इतने एडवर्स रिएक्शन से होने वाले एडमिशन नंबर ऑफ डेज कम हुए. इतने फार्माकोविजिलेंस प्रोग्राम आने के बाद में इतने दिन तक फार्माकोविजिलेंस से डेज जो लॉस हो रहा था, convert this into pharmacoeconomics के इतने रुपया हमारा कन्वर्ट हुआ. Then we can say to government, return of investment क्या है. Government ask always what is ROI, return of investment क्या है. हमने 500 करोड़ उसमें खर्च किए, तो ये देखिए रिटर्न ऑफ इन्वेस्टमेंट हमारा 5000 से करोड़ से ज्यादा है. इतनी लाइफ बची, इतने हॉस्पिटल डेज बचे, इतने ह्यूमन रिसोर्स का वर्किंग डे कम हुआ. And that is what now the next is. नेक्स्ट प्रोग्राम इज, वी आर सेइंग कि इस ड्रग से साइड इफेक्ट यहाँ पे होता है, यहाँ पे नहीं होता है. तो क्या हम ऐसा प्रोग्राम बना सकते हैं कि फार्माकोजीनोमिक्स, टॉक्सिकोजीनोमिक्स प्रोग्राम, सो दैट वी कैन से कि दिस ड्रग इज कॉजिंग साइड इफेक्ट हियर एंड नॉट. एंड वो हमारा, yesterday I was talking in CII meeting, and the pharmacogenomics has said कि हमारे pharmacovigilance program is promoting this program, and ICMR in fact has created a task force on pharmacogenomics. ये इसके लिए हमें डेटा इकट्ठा करना है. और राजीव जी ने ठीक कहा कि डेटा हमारे पास, अब हम ऐसे नहीं कर सकते कि हम मैनुअल कर रहे हैं. You have to develop a program. और इसके लिए कोई भी, इतने हमारे IT एक्सपर्ट्स हैं, तो why not we develop a perfect program, coordinated program, isolated करने से नहीं. हमने जब ये प्रोग्राम कहा था, when we thought of PVPI, हम उपसला मॉनिटरिंग सेंटर से पासवर्ड लेते हैं. अरे भाई कब तक उनका पासवर्ड लेके हम यूज करते रहेंगे. एंड राइट फ्रॉम द बिगिनिंग आई हैव बीन पुटिंग एम्फेसिस, व्हाई नॉट वी हैव आवर ओन द प्रोग्राम. एंड आई थिंक NIC इज डूइंग इट, बट नेशनल इंफॉर्मेटिक्स सेंटर्स को हमें आई थिंक थोड़ा सा पुश करना पड़ेगा कि सीडेक. तो सीडेक वाले को हम, मतलब हम कहीं ना कहीं से ये जो ऑब्स्टिकल्स आते हैं इनको दूर करके अपना ओन प्रोग्राम अगर बना सके, तो आई थिंक दैट वुड बी समथिंग वेरी गुड. एक इम्पॉर्टेंट चीज ये भी है कि ह्यूमन रिसोर्स विच वी टॉक अबाउट, फार्माकोविजिलेंस हैज गिवन ए बिग बूस्ट टू ह्यूमन रिसोर्स. अब हर इंडस्ट्री में एक फार्माकोविजिलेंस का ऑफिसर होता है. हमने अपने सैकड़ों pharmacovigilance associate किए, and about 3 months back, no 3 years back, we converted post of pharmacovigilance associate to senior pharmacovigilance associate. और उसके बाद में हमारे ये तैयार किए हुए लोग छोड़ के जाते हैं दूसरी जगह पे. हम नहीं चाहते, and it is not possible also to retain them. लोग कहते हैं कैसे रिटेन करें. भाई क्यों रिटेन करो. Once our objective is also to create human resource, like universities. Now we have become that big that we are creating human resource in pharmacovigilance. And this trained person are getting absorbed in industry or in other houses at 3 times or 4 times the salary which they're getting now. So we have to see that what vertical of human resource we can create. क्या हम इतना अपने ह्यूमन रिसोर्स को ट्रेनिंग से इतना पक्का बना रहे हैं that they will become the top of pharmacovigilance experts ready for industry. That is something vertical is important. And फिर लास्ट में हम ये कहेंगे कि हमें 100 वॉट का आंसर हमने दिया, व्हाट नेक्स्ट का आंसर हमने दिया, अब व्हाट मोर को हमें सोचना है. एंड आई एम वेरी हैप्पी कि डॉक्टर मंटू भाई यहाँ पे आए हैं. तो हमारे फार्म डी वाले इतने हैं, हम अभी 2-3 दिन पहले बात कर रहे थे कि फार्म डी वाले को मंत्री जी से भी बात हुई कि हर मेडिकल कॉलेज से हम जोड़ें. एंड दिस वुड बी द ह्यूमन रिसोर्स विच कैन इंटरेक्ट. हम साइलो में काम करके बंद करके हम आपस में इंटरमिंगल करें. एंड वन ऑफ द इम्पोर्टेंट थिंग इज द फार्माकोविजिलेंस, मटेरियल विजिलेंस, हीमो विजिलेंस. So this will be something very good. And राजीव जी से मोटिवेट होकर मैं भी एक शेर पढ़ दूंगा लास्ट में, that so that कि हमारा प्रोग्राम इतना स्ट्रांग होना चाहिए ना कि WHO अभी पूछता है कि भाई ये दवाई हटाएं, हम WHO से पूछते हैं, अरे भाई WHO से हम कब तक पूछते रहेंगे? Let WHO ask us, let the globe ask us, because हमारी पॉपुलेशन 140 करोड़ और हम पूछ रहे हैं किससे, जिसकी पॉपुलेशन 1 करोड़ से भी कम है. डॉक्टर मधुर गुप्ता. अरे मधुर गुप्ता, I am very happy that Madhur is listening. Convey this to WHO that we are becoming so big that, and she will also feel pride that WHO is asking India that whether we should, because data has a power, information, and that is what. So I will say, खुदी को कर बुलंद इतना means your data should be so powerful, meaningful, not only powerful. खुदी को कर बुलंद इतना कि हर तकदीर से पहले, means every decision about the drug, खुदा बंदे से खुद पूछे, the WHO हो चाहे USFD हो चाहे कोई भी हो, what we call them, refer them as खुदा. We are खुदा now. खुदा बंदे से खुद पूछे, बता तेरी रजा क्या है? Tell me, what is your opinion? This is motivation of Rajiv. Thank you very much.
Thank you. Thank you very much, sir. First of all, sharing your memories with us and boosting us with your encouraging words and sharing the future objectives as well. So thank you so much. Now I request Dr. Rajiv to kindly felicitate Professor Y.K. Gupta for his appreciable contribution to Pharmacovigilance Program of India. Thank you, sir. Thank you so much. May I now invite Dr. Kiran Kumar Karlapu, Deputy Secretary, Drugs Regulation, Ministry of Health and Family Welfare, Government of India, to address the gathering.
Thank you. Respected Y.K. Gupta ji, respected Raghuvanshi sir, Ruben Abbas ma'am, Montu Patelji. Thank you for inviting me on this August occasion. Actually, yesterday I had spoken to Raghuvanshi sir, and sir had told me that we have given you 10 minutes to speak, but then I had developed cold feet yesterday. So I requested sir to kindly delete my name from the list of the speakers. But after coming here, and I'm a doctor by training. So after coming here and looking at the ambience, and when Jayaprakash ji had told me, sir, are you still willing to speak? I said, yeah, certainly, I would love to speak here. And so I understand that the theme for this year's National Pharmacovigilance Week is encouraging reporting of adverse drug reactions by patients So I've studied in a government medical college. So for a doctor, this could be very low on the priority list. And for an Indian perspective, when we look at it, reporting an adverse drug reaction, again, is not on the top of your priorities. There's several reasons why you do not report an adverse drug reaction in India. You started off with a traditional Indian way of dealing with an adverse drug reaction. Okay, fine, maybe something is wrong with me. That is our innate, how we have been brought up. That we blame ourselves. Maybe I took the wrong medication. Maybe I should have taken it before meals. I took it after meals, or maybe I had eaten something else. Maybe the drug didn't work. Then you have the trust in the doctors and in the healthcare system. The doctor couldn't have been wrong. So that is one reason we are so hesitant to report an adverse drug reaction. Secondly, a doctor or a nurse or a pharmacist will not report a drug reaction normally because of the strictly hierarchical system in which doctors are raised. So the professor is always correct for the postgraduate, for the assistant professor, is always correct for the postgraduate. The PG is always God for the UG. So you never find someone, you cannot imagine that your boss could have made a mistake. So that's the strict hierarchy that is there in medical colleges. So this discourages reporting an adverse drug reaction. Then the concern over the consequences of reporting an adverse drug reaction. Nobody would be like to called a snitch. Why have you reported it? It would have been taken care internally. Then the idea of the possible legal ramifications of reporting an adverse drug reaction. So who will decide whether it was a therapeutic misadventure or it was medical negligence? So that immediately ties your hands when you would want to report a drug reaction. But this program that you have started here, the pharmacovigilance program, I think will go a long way in changing the perspectives that doctors and healthcare professionals have. That reporting an adverse drug reaction is in line with the larger goal of patient care, the larger goal that the oath that all of us have taken as doctors, that the patient comes first. So whenever we are wrong, it is a duty to report an adverse drug reaction. Possibly could not have been your wrong. Possibly there were some other issues which have caused the drug ADR. But it is the first step is to report. And I have made to understand that the pharmacovigilance program right now is completely based on voluntary reporting by the institutes. So I am 100% sure, and all of us are sure, that the amount of reporting that is going on right now must be very, very low when compared to the actual drug reactions. So the next step, so the next challenge that IPC has and this program has is how to increase reporting of ADRs. So, sir, with all due respect, I would like to give a few suggestions how we can take forward this program. First thing is, a large percentage of Indians self-medicate, including all of us. I had a sore throat a few weeks ago, and the first thing I did, I took an Azith. So that is what. And so who will report in ADR when it's self-medicated? So you have a mobile app. You can probably make it anonymized. So I do not report my name. I do not report my my other details. But obviously, we do need a basic case history. You can ask for that so that it goes into your database. Secondly, like countries all over the world do, we have big data. We have what we call OSINT, open source intelligence. Probably we can start thinking of looking at people sharing their adverse drug reactions on social media, on Twitter, on Insta. When someone says, I took this medicine yesterday, something went wrong, it could probably give you a sort of a suo moto understanding of what is happening rather than completely relying on your partnership organizations for reporting ADRs. Then I think we should all look forward, since we are all under the Ministry of Health and Family Welfare, we should all look at how to make reporting of ADRs a part of nursing, medical and pharmacy curriculum. Should be probably included in the textbooks, that yes, a chapter, a footnote, a few pages, that there is a program. When it's in your textbook, you look at it. So how to make it a part of your curriculum as well. Secondly, mandating reporting of ADRs through all institutes. We have reached out to government medical colleges, reached out to large hospitals. But as sir was saying, now we have to move in to the secondary centers, the primary health centers. Here, technology helps. Through your mobile apps, you can start teaching and teaching and encouraging people who look working in PHCs, probably your ANMs, your ASHA workers also. Make it so simple that even they can, on basic in their own mother tongue, probably report an adverse drug reaction. All we need is a few little medical history details. That what need to start off a basic idea. Then after probably we need to have an automatic sharing of data between IPC and CDSCO, where what next? Because the enforcer, the regulator is CDSCO. Whatever ADR has been reported by IPC should probably automatically share to CDSCO, so they can start off with some. CDSCO may again consider that all approvals that are given to a new vaccine, to a new medicine, would also contain some robust post-approval monitoring system, that where the vaccine manufacturer, the person who is applying for the license would have to authenticate, would have to certify that in case of an ADR, yes, I have a program in place, I have set aside some funds in place. If there is an ADR reported because of this medicine that you are licensing, the only person who has the regulatory control over the industry is the CDSCO. Probably we can look at some sort of an introduction into the rules as well. And yeah, I think that is what I would like to say. I've last minute I've scribbled some notes, so I possibly made my point. And all of us growing up, I've grown up on Robin Cook's novels, and half of Robin Cook's novels are about doctors trying to play God, and doctors getting caught, and then one guy who tries to fight the system and somehow succeeds. So as Raghuvanshi sir and Gupta sir have ended their speeches with a shairi, but I am from the south, so you cannot expect a shairi from me. So, but what I could tell you is something from Sanskrit. What we was something which we were taught in our medical college. A quote from the Garuda Purana. It says that Aushadam Jahnavi Toyam Vaidyo Narayano Harihi. That is, medicine is equal to the sacred waters of the Jahnavi, the Ganga river, and Vaidyo Narayano Hari, and the doctor is God. So the couplet starts off equating medicines with the sacred river Ganga. And so that is the importance that this program would have in ensuring that medicines remain safe for patients. Thank you.
Very, very thank you, sir, for sharing your thoughts with us and your suggestion to boost the reporting areas for common people. So thank you so much. Now I would like to invite Dr. Rubina Bosch, Deputy Drugs Controller General of India, Central Drugs Standard Control Organization, Government of India to address the gathering.
Thank you for this kind invitation. And I think I'm out of this as I won't have any control or any capacity to say any share, but it was so motivating to listen to all the speakers and the panelists. Like, thank you, Dr. Y.K. Gupta sir, Dr. Rajiv Raghuvanshi sir, then our Deputy Secretary. So if they were all so spontaneously speaking. But anyway, I would just like to carry out from this what was spoken earlier. So it is really, first of all, I really congratulate. I'm so, because I started when Y.K. Gupta sir said in 2005 in the first training program of pharmacovigilance, and also the Uppsala's training in 2008-9. So I attended all these in AIMS when Y.K. Gupta sir was our trainer. So I started long ago with this program. So I'm a part of it as a regulator since then. So that was one of the things, just to connect with the history and how CDSCO started and opened the Pharmacovigilance Center in different states in the each zonal zones, and then how it was converted to the spontaneous many adverse monitoring centers. So initially it was like opening adverse monitoring centers in each of the zones was a compulsory, with the giving and system, with the data entry operator, the technical data operators and all those things. So there was like giving the technical people and opening the centers, and then it became such a big program where now we have more than 600. And it was like the listening to the figure was it was very encouraging to listen to this, and probably the National Pharmacovigilance Week with its theme has brought this into, like, as I heard that 33,000 participants were a part of it. And we already know that India is in the 9th in the rank in reporting. We have almost like 1 lakh now reported, and we are crossing every year 1 lakh. So that these are all like a huge motivating figure. And being a continuous partner, like as the regulatory agencies, as sir was saying, our deputy secretary sir was saying that regulators have a specific role in this pharmacovigilance. And I know that everybody is aware of it, that we have in the law the post-marketing surveillance, the 5th schedule, as like the 7th schedule in the medical device. So we have the 5th schedule in the new drugs and the clinical trial rules, which says about the post-marketing surveillance. And the pharmacovigilance is one of the most important part, other than the post-marketing surveillance studies. Then submission of the periodic safety update reports, which is a compulsory mandatory part. Like every manufacturer who is given a permission for marketing the drug, a new drug, they have to submit the post-marketing, the periodic safety update report 6 monthly, and for 2 years, and then annually. So this is a 4 years. And then the also it's a requirement for products like biologicals for a continuous reporting under product life cycle. And also it's a in the finally we also the CDSO along with the pharmacovigilance program of India and with all the experts have come up with the CDSO, the guidance document of pharmacovigilance, which says about reporting of the adverse drug reaction throughout the product life cycle by all the marketing authorization holder or the manufacturers. So these are already in the law, and the regulation is in place, where adverse drug reaction monitoring is adverse drug reaction reporting is a compulsory requirement under the licenses as well. Like if the good manufacturing practices guidelines also say that each manufacturer has to report the adverse drug reaction as soon as it is once it is received, they have to collate, analyze, and report it to the licensing authority. So that's a process which goes on. And so really, I know that everybody is aware of this. For just to reiterate the same, so it is the regulation is in place, and we also have the added regulation which came in 2016, where there is a requirement of the pharmacovigilance officer, and also the who should be the qualification, and everything is described, and that is a compulsory requirement for all the manufacturer of the new drug. They should have. And also the guidance document says that all the manufacturers who are manufacturing and marketing drug in the country, they should be having this adverse drug reactive reporting personnel in their facility. So the regulations are there, and actually the one which is there, even if the regulations are there, implementation is the most important part, and the most important function and implementation work has been actually carried out by this very motivating, how the pharmacovigilance program has grown from 2011. I think it's in leaps and bounds rather than in a baby steps. Like it is how the centers have increased, how the reporting system, and how their continuous endeavor in training, capacity building, continuous training in a year, the four times, the even expanding this program to the CRN region. And there I have been part of this, like Asia Pacific country, in the training program, in which the different countries, including even the African countries, also take part with it. So, and where all the people from the facilitator from the Uppsala is also a part of it to train the participants. So I think it is growing in leaps and bounds. And when I hear director, the secretary sir, and also YK Gupta sir, I understand that like it's really all the places we don't find so much motivation to work, but it is a place when we hear this, that yes, it is really a motivating story. And the inclusion of the Metro Vigilance program and the Hemo Vigilance program together. So all are like a very encouraging story for the regulators. And also we are always committed to work along with the partners and the stakeholders, and along with definitely the PVPI program of the National Coordinating Center, wherever the regulatory actions are required. As it is said that the 11 signals which has come out of our own national area reporting system, where the signal review panel has analyzed the data, and signals have been detected, and also wherever there are safety updates are being required for the various prescribing information. So such regulatory actions are always taken up as it is communicated for communication and for safety update reports. And as it is said that now we have our own database, so definitely whenever a safety report is being heard about for any such drugs, definitely we always, it is so easy now to refer to the pharmacovigilance program, to the National Coordinating Center, to get what is the country's database, which probably we had never had before. But sir was saying that we used to say which this is the data of the US, and now we can say, okay, this is a new safety signal, and we have the data, we can get our own country's data. So it's a real support for the regulatory system, and it is one of the important functions, the pharmacovigilance adverse drug reaction reporting of the drugs and the vaccines, as well including the pharmacovigilance. So this is one of the, I think Dr. Madhur is there, so she will be definitely looking into this, that she will be covering this, that it is the one of the most important functions where we have really, because of the contribution of the National Coordinating Center and PVPI, we have scored a high marks of global in the global benchmarking system. Also, that is another success story. So definitely. So I'm so thankful to be a part of this gathering, and this event of inaugural of this session of this National Pharmacovigilance Week, to make this program, and also to encourage and have more supporting, and definitely it will go more towards making a really important adverse reaction reporting system more useful for the country. And as sir has always said, that we would always say that the quality of the data is very important. Quality of reporting is also important. So those things will be definitely covered up. So thank you. And I cannot really, I'm not able to give any such good quotes. So thank you very much.
Thank you so much, ma'am. Thank you very much, ma'am, for your very kind words. May I now invite Dr. Montu M. Patelji, President, Pharmacy Council of India, to address the gathering. Please, sir.
Good afternoon to all. Thank you, Rajiv Singh, Raghuvanshi जी, YK गुप्ता जी जो एम्स के डायरेक्टर्स भी हैं, किरण कुमार कर्पूरी डेप्यूटी सेक्रेटरी, डॉक्टर रुबीना बोस डेप्यूटी ड्रग कंट्रोलर, डॉक्टर राजेंद्र पी जोशी जी एंड भावतोष सदांकर जी एंड WHO के रिप्रेजेंटेटिव, और बहुत सारे जो कलीग्स फार्मासिस्ट हैं, या तो बहुत सारे रिप्रेजेंटेटिव डिफरेंट ऑर्गेनाइजेशन से आए हो। तो फार्मेसी काउंसिल इंडिया का जो रोल है, जैसे बताया YK गुप्ता सर ने भी बताया, और पहले तो मैं राजीव सिंह रघुवंशी जी को धन्यवाद देना चाहता हूँ, क्योंकि जो हमारा IPC लॉन्च हुआ तब मैं प्रेजेंट था, और आपने अदर कंट्री में भी हमारा फॉलोअप शुरू किया है, हमारा फॉलोअर्स बनने लगे हैं कंट्री। तो एक पॉजिटिव साइंस है कि जो आपका काम पूरे वर्ल्ड में दिखने लगा है। तो आगे जाके भी जैसे गुप्ता सर ने बोला कि इंडिया को ही विश्व गुरु ही बनाना है हमको, जो हमारे प्रधानमंत्री का जो उद्देश्य है कि इंडिया को एक ब्रांड बनाना है। तो इंडिया के लिए आप लोगों ने जो टीम्स, इंडियन फार्माकोपिया कमीशन जो काम कर रही है, और डिफरेंट स्टेक होल्डर के साथ ज्वाइंट हैंड करके भी कर रही है, तो सही में सर आप अच्छा काम कर रहे हो और आप मुझे यहाँ बुलाने का एक अवसर दिया मुझे इधर आने का, और सही में मैं धन्यवाद देना चाहता हूँ पूरी आईपीसी टीम को। बात करते कि मैंने प्रेजेंटेशन देखा कि पीवीपीआई की एप्लीकेशन भी बनी है, टोल फ्री नंबर भी है, स्किल डेवलपमेंट प्रोग्राम भी आप चला रहे हो। पर अभी मेरे नॉलेज में या तो फार्मेसी काउंसिल इंडिया के नॉलेज में या तो बहुत कम लोगों के नॉलेज में आता है चीज़। अगर हम कोलैबोरेटिव जो भी काम करना चाहते हैं एज अ फार्मेसी काउंसिल इंडिया और आईपीसी, तो बहुत सारा जो 25 to 30 लाख फार्मासिस्ट हमारे ऑलरेडी कम्युनिटी में, इंडस्ट्री में है, तो गवर्नमेंट ऑर्गेनाइजेशन में, तो पूरा सपोर्ट आईपीसी को भी मिलेगा और हम भारत सरकार को और हेल्थ हेल्थ मिनिस्ट्री में जो सपोर्ट चाहिए वो हम दे सकते हैं एज आ सारे वर्कफोर्स फार्मासिस्ट मिलकर। तो उसको भी हम प्रमोट करने के लिए आपके साथ हैंड टू हैंड मिलाएंगे। और जो फार्मडी के अभी तक 250 हमारे फार्मडी के कोर्स पूरे इंडिया में चल रहे हैं। अभी इस साल भी नई एप्लीकेशन आई, तो इस साल भी 50 to 60 नए कोर्स हम देने वाले हैं। तो कुल मिला के 300 जो फार्मडी के कोर्स चलते हैं वहाँ वो लोग 300 बेडेड हॉस्पिटल के साथ टाइप करते हैं। अगर वहाँ पे भी आपने फार्मा को विजिलेंस सेंटर दे दिया या तो फार्मडी स्टूडेंट को एंगेज कर लिया वहाँ कोई पायलट प्रोजेक्ट के रूप में, एडवर्ट ड्रग रिएक्शन मॉनिटरिंग, या तो जो भी आपकी सिस्टम में वो सूट होता है एज अ टेक्निकली लीगली, तो एटलीस्ट हमारा काम 20-30% पॉजिटिव हो जाएगा और नेक्स्ट ईयर हम अलग एक स्टेज पे पहुंचेंगे। तो आपको ये थोड़ा मेरा रिक्वेस्ट है फार्मेसी काउंसिल इंडिया की तरफ से कि फार्मडी स्टूडेंट के जितने भी कोर्स हमारे चलते हैं अच्छे और अच्छे अच्छे हॉस्पिटल में उनकी ट्रेनिंग भी रहती है 1 साल के लिए, तो अगर वहाँ आपने दे दिया सेंटर तो बहुत ही एक इंडिया के लिए हमारा जो एडवर्ट ड्रग रिएक्शन मॉनिटरिंग को एक सपोर्ट करने के लिए इतना बड़ा वर्कफोर्स, क्योंकि 7,500 फार्मडी स्टूडेंट एवरी ईयर पास आउट्स होते हैं, तो इतना बड़ा वर्कफोर्स आपको पहले दिन से मिलना शुरू हो जाएगा। तो एक सपोर्ट सिस्टम आपको आईपीसी को मिलेगी। और एमफार्म में जो बहुत सारे क्लिनिकल फार्माकोलॉजी स्टूडेंट्स है वो भी आपको सपोर्ट में आ सकते हैं। और डिप्लोमा की बात करें, भले हमारा डिप्लोमा का कोर्स 2 इयर्स का है, पर जो डिप्लोमा के स्टूडेंट्स इतने नॉलेजेबल होते हैं प्रैक्टिकली कम्युनिटी वाइज, कम्युनिटी फार्मासिस्ट में, कि बैचलर स्टूडेंट से भी ज्यादा वो स्किल्स ज्यादा रखते हैं कि कोई भी दवाई कैसे लेनी है, इसका एडवर्ट ड्रग रिएक्शन क्या है, वो तुरंत बोल देते हैं क्योंकि वो ही पढ़ते हैं 2 साल में। सिर्फ वो फार्मा को फार्माकोलॉजी पे ही ज्यादा वो लोग फोकस करते हैं। तो अभी मुझे लगता है कि आने वाला जो सिलेबस भी हम चेंज करने वाले हैं, क्योंकि फार्मडी का जो वर्कफोर्स है पूरे इंडिया में बहुत ज्यादा है। साढ़े आई थिंक 1500 इंस्टीट्यूशन डिप्लोमा स्टूडेंट के हैं, तो 2.5 लाख बच्चे हर साल पास आउट होते हैं। तो वो भी अगर अच्छे मेडिकल स्टोर या तो अच्छे पूरे इंडिया में इतने आइडियल फार्मेसी स्टोर्स है, अगर उनको भी आपने आइडेंटिफाई कर लिया, तो बहुत सारे पेशेंट की जो एडवर्ट रिएक्शन आती है दवाई लेने के बाद, तो सीधा पहले ही वो फार्मेसी स्टोर पे ही जाते हैं कि मुझे ये रिएक्शन आए दवाई खाने के बाद। तो एक सिस्टम वो भी है कि जो ड्रग कंट्रोल डिपार्टमेंट के साथ आप टैप करके या तो फार्मेसी काउंसिल इंडिया के साथ टैप करके हम एक पैरेलली सिस्टम इफेक्टिव जो एडवर्ट ड्रग रिएक्शन रिपोर्टिंग होनी चाहिए जो एक्चुअली मार्केट में दवाई बिक रही है, तो मुझे लगता है कि ये हो जाएगा। और पूरे वर्ल्ड में हम सप्लाई दवाई कर रहे हैं, जैसे हम बना रहे दवाई सारी, फिर पूरे अदर कंट्री वाले हमारी दवाई बैन कर रहे हैं, पर पहले हम ही अच्छी तरह, जैसे गुप्ता सर ने बोला कि हम ही क्यों ऐसा डेटाबेस क्रिएट ना करें कि हम ही पहले उसको बैन करने वाले भी हम पहले ही होने चाहिए कि पूरे वर्ल्ड को हम अच्छी दवाई खिलाएंगे। तो उसके लिए भी बहुत ग्रास रूट का आप रोड मैप बनाओगे, तो उसके लिए पीसीआई भी सपोर्ट आपको करने के लिए रेडी है। और बहुत सारे हमारे फार्मेसी इंस्टीट्यूशन भी ऐसा है कि वहाँ इतनी बड़ी यूनिवर्सिटीज है या तो इतने बड़े इंस्टीट्यूशन है कि वो लोग अच्छा काम करते हैं रिसर्च के लिए, इसके लिए। तो एडवर्ट ड्रग रिएक्शन के लिए हम हमारा सिलेबस जो हमारे हेल्थ मिनिस्टर साहब के विजन से हम चेंज करने वाले हैं अभी अगले साल, तो उसमें भी हम कम्युनिटी फार्मासिस्ट के लिए पूरा चेंज करने वाले हैं और इंडस्ट्री ओरिएंटेड बनाने वाले हैं। तो वो भी हम डिफरेंट करने वाले और एम्फामिन मेजर करने वाले। उसमें ये जो टॉपिक है फार्माको विजिलेंस एडवर्ट ड्रग रिएक्शन, उसके लिए एमफार्म का एक अलग ही स्पेशलाइजेशन हम मेजर करके हम शुरू करने वाले, कि जिससे ज्यादा अवेयरनेस फार्मासिस्ट में आए और ज्यादा से ज्यादा हमारी हेल्थ केयर सिस्टम को हम सपोर्ट कर पाए। तो सारी चीजें हम आने वाले समय में चेंज करने वाले, या तो हमारे रोड मैप में है, तो उसमें आपका सपोर्ट चाहिए, क्योंकि आईपीसी अगर हमारे साथ ये फार्माको विजिलेंस और एडवर्ट ड्रग रिएक्शन जो भी मॉनिटरिंग सिस्टम को मजबूत बनाना चाहते हैं हम साथ में मिलकर, और भारत को एक मजबूत जो भी हेल्थ केयर सिस्टम में जो भी सपोर्ट कर पाए, हम आईपीसी पीसीआई या तो सीडीएसयू, अगर हम जॉइंटली हैंड कोर्स करिकुलम बनाने में करेंगे, तो मुझे लगता है कि आपको एक पहले ही दिन से एक प्रॉपर आपको सिस्टम मिलेगी, जिससे एडवर्ट ड्रग रिएक्शन रिपोर्टिंग शुरू हो जाएगी। पर अभी जो आपका मैं डेटाबेस देख रहा था, आपकी मेहनत से अच्छा ग्राफ चल रहा है, पर वो ग्राफ डबल हो जाना चाहिए, वैसी मेरी इच्छा है कि कैसे भी करके हम साथ में मिलकर काम करें, तुरंत डबल हो जाए। तो ये बहुत सारा काम हम आईपीसी के साथ मिलकर कर सकते हैं, और पीसीआई आपको पूरा सपोर्ट देने के लिए रेडी है, क्योंकि हमारे पास तो वर्क फोर्स पड़ा ही है फार्मासिस्ट का, वो यूटिलाइजेशन करना ही बाकी है। उसको कैसे यूटिलाइजेशन करना है, अगर हम लीगली टेक्निकली रोड मैप बना लेंगे, तो मुझे लगता है आपके पास पहले ही दिन से वर्क फोर्स काम में आना शुरू हो जाएगा। और जैसे एम्स में भी बहुत सारे जो प्राइवेट हॉस्पिटल है, जैसे अपोलोस है, वहाँ फार्मडी स्टूडेंट ऑलरेडी अभी काम कर रहे हैं, क्योंकि पेशेंट काउंसलिंग का काम फार्मासिस्ट का है। आपको पता हो कि पेशेंट एक डिपार्टमेंट का अगर ऑर्थोपेडिक में दिखाने गया, बाद में फिर आई डिपार्टमेंट में गया, बाद में अलग अलग डिपार्टमेंट होते हैं एक हॉस्पिटल्स में, बाद में वो सारे ही डॉक्टर एक मर्ज करके दवाई देते हैं साथ में। वो दवाई सिर्फ अकेला फार्मासिस्ट ही समझ सकता है कि इतनी सारी दवाई उसकी एडवर्ट ड्रग रिएक्शन क्या आएगी, या तो दो दो बार एंटासिड प्रिस्क्राइब कर दी होती है। मॉलिक्यूल अलग होते हैं, कोई राबिप्राजोल लिखेगा, कोई पेंटोप्राजोल लिखेगा, कोई पेन किलर एसिक्लो लिखेगा, कोई डाइक्लो लिखेगा, या तो कोई हायर एंटीबायोटिक्स लिखेगा, कोई लोअर लिखेगा। बाद में सारी दवाई मिक्स होती है एक ही जगह पे, जहाँ फार्मासी स्टोर ही होता है। तो फार्मासी स्टोर ही एक ऐसा है कि जहाँ आपको प्रॉपर एक सपोर्ट सिस्टम आपको दे सकता है। तो इसीलिए फार्मासिस्ट का रोल जो अदर कंट्री में है, इसीलिए इम्पोर्टेंस रोल है कि पूरी दवाई का नॉलेज वो रखते हैं कि कौन से ऑर्गन पे कितनी इफेक्ट आने वाली है, या तो उसका एडवर्ट ड्रग रिएक्शन है, कब खाना है। तो मुझे लगता है कि अगर हम इंडियन हेल्थ केयर सिस्टम में भी जैसे फार्माको विजिलेंस सेंटर काम कर रहा है, अगर हम फार्मासिस्ट को एक प्रॉपर तरीके से हम गाइड करेंगे, तो उसके लिए भी जो आपकी एप्लीकेशन है उसको हम ज़्यादा प्रमोट करेंगे, तो तुरंत हमारे पास रिपोर्टिंग सिस्टम आना शुरू हो जाएगी। तो बहुत ही अच्छी तरह से हम काम कर सकते हैं। और बहुत सारे लोग सीडीएसयू से और रेगुलेटरी से जुड़े हुए हैं। अगर फार्मासिस्ट को हमने प्रॉपर तरीके से इंडिया में यूज़ किया हमारी सिस्टम में, तो एक बहुत ही अच्छा, क्योंकि डॉक्टर के पास टाइम नहीं है कि डॉक्टर अगर पेशेंट देखेगा, तो पेशेंट के बाद उनका फॉलोअप का भी टाइम नहीं है, और दवाई लेने के बाद उसको क्या एडवर्स रिएक्शन आई वो भी रिपोर्टिंग का टाइम नहीं है। वो सिर्फ क्योंकि पॉपुलेशन हमारी ज़्यादा है, डॉक्टर्स कम है, वो भी हम समझ सकते हैं। तो फार्मासिस्ट को प्रॉपर यूटिलाइज करके हमारी हेल्थ केयर सिस्टम है, तो फार्माको विजिलेंस एडवर्ट ड्रग रिएक्शन मॉनिटरिंग जो भी सिस्टम बनानी है, हम अच्छी तरह बना के, क्योंकि हमारा भारत सरकार का जो ज्यादा खर्चा है जो हेल्थ केयर का, वही एडवर्ट ड्रग रिएक्शन होने के कारण है। तो मल्टीपल दवाई लेने के कारण हमारा हेल्थ केयर में भी एक्सपेंस ज्यादा बढ़ रहा है डे टू डे, क्योंकि पॉपुलेशन भी बढ़ रही है। तो हमारा हेल्थ केयर जो कॉस्ट है मेडिसिन का, वो भी बढ़ रहा है। साथों साथ हमारे जो हॉस्पिटल बनाने का भी बर्डन हमारा बढ़ रहा है। तो अगर यहाँ एक चेक पॉइंट है, क्योंकि यही स्टार्टिंग पॉइंट है एडवर्ट ड्रग रिएक्शन का, यहाँ हमने प्रॉपर कंट्रोल कर दिया, तो बहुत सारे पेशेंट को हम, या तो भारत सरकार का भी फंड हम बचा सकते हैं, और पेशेंट को भी एडवर्ट ड्रग रिएक्शन से बचा सकते हैं, और उनको गलत दवाई देने से, या तो कोई मल्टीपल बीमारी होने के कारण वो दवाई लेते हैं, तो उनको भी हम अच्छी तरह से गाइड कर सकते हैं। तो यही है, फार्मेसी काउंसिल इंडिया का सपोर्ट हमारा आपके साथ है, और हम भी आपका सपोर्ट चाहते हैं कि फार्मासिस्ट का पूरा डेवलपमेंट हो। और वाई के गुप्ता जी का भी हम सपोर्ट चाहेंगे, क्योंकि इसमें भी हमको एक प्रॉपर बेस मॉडल बनाना है कि पूरा इंडिया उसको फॉलो करे। और सीडीएसयू भी मैडम भी है, तो फार्मासिस्ट का इम्पोर्टेंस डे बाय डे बढ़े, वैसा पीसीआई का एक कॉन्सेप्ट और कोर्स करिकुलम में सभी स्टेक होल्डर का सपोर्ट चाहिए और आप लोगों ने मुझे इधर इनवाइट किया, मेरा वर्ड्स रखने का मुझे मौका मिला। थैंक यू। जय हिंद, जय भारत।
Thank you so much, sir.
Madhu,
Yes, sir.
So, Dr. Montu, thank you very much. आपने जो सारी बातें की, एक रिक्वेस्ट है जो मुझे लगता है कि जितना भी आपने अभी रखी बातें अपनी, वो सारा हम उसको एग्जीक्यूट कर सकते हैं। आप पीसीआई में एक आदमी को कोई कोऑर्डिनेटर बना दो जो आईपीसी उनके साथ डील करेगा। आप पास टाइम कम है, आप पूरे देश घूमते रहते हो, कोई एक एक्टिव आदमी को जिसको थोड़ा सब्जेक्ट का नॉलेज हो, उसको आप एक कोऑर्डिनेटर बना दो, सिंगल पॉइंट कॉन्टैक्ट, एंड ये सारी चीजें हम लोग कर लेंगे।
श्योर श्योर। थैंक यू, थैंक यू।
Thank you so much, sir, for showing your interest and support to PVPI and IPC. So thank you once again. May I now invite Dr. Madhur Gupta, National Professional Officer, WHO Country Office of India, to address the gathering.
Namaste, good morning, and I hope I am audible.
Yes, ma'am.
Yeah.
Go ahead.
Yeah, so very, very warm good morning to all the dignitaries and all the doyens of pharmacovigilance who are present today and gracing the occasion. Dr. Kiran Kumar, Dr. Rajiv Raghuvanshi, Professor Y.K. Gupta, Dr. Nilima Shirshagar, Dr. Thatte, Dr. Rubina Bose, Dr. Montu Patel, everybody. Very, very warm good morning. It's a pleasure to be here this morning amongst all of you for the celebration of the National Pharmacovigilance Week and today's inaugural session flagging off the National Pharmacoweek celebrations. It is indeed a long way that Pharmacovigilance Program of India has come today. As Professor YK was highlighting, and Rubina also touched upon that, it is my proud privilege also that I have been associated with the pharmacovigilance program since 2005, almost more than 17, 18 years now, and since All India Institute of Medical Sciences. And then it's transitioned to Indian Pharmacopoeia Commission as Pharmacovigilance Program of India, and the huge role it has played in moving to each and every public health program, whether it is tuberculosis, malaria, vector-borne diseases, the whole area of vaccines, safety monitoring of vaccines to be established. It has grown by leaps and bounds over the past many years. And it's indeed a pleasure how, the journey of pharmacovigilance program has been over the past many years. The government of India has committed a lot of funds and support, including, the seamless involvement of Regulatory Authority of India, as Dr. Rubina had mentioned. The pharmacovigilance in India is actually at quite an advanced level. And this is now being looked at in the regional level amongst countries, how the other countries are looking at replicating what the systems in India, etc. The focus of today's celebration also is that today is the World Patient Safety Day, 17 September 22. And the campaign or the call is medication without harm. And that is the slogan for the celebrations today. Pharmacovigilance program has played a key role in also the benchmarking of India, the regulatory benchmarking, as Dr. Rubina had touched upon. And India actually played, the vigilance, strong vigilance system in India played a critical role in getting, highest maturity level of 4 marks, which is the highest possible in the WHO regulatory benchmarking in India, which was conducted in 2017. So quite, a huge role played by the seamless collaboration and cooperation of CDSCO, the Pvpi, the Hemo Vigilance Program of India, and the Material Vigilance Program of India. I have just a few slides, and I would like to just share with you broadly, what is the theme of today's World Patient Safety Day on the 17th September 22. And this is flagging of the National Pharmacovigilance Week, India. The World Patient Safety Day, which happens to be today, actually is one of the WHO's global public health days. And it was established in 2019 by the 72nd World Health Assembly Resolution, WHA 72.6, Global Action on Patient Safety. And subsequently, this whole area of pharmacovigilance gained momentum. As we know, unsafe medication practices and medication errors are a leading cause of avoidable harm in the healthcare system across the world. And this is preventable. More than half of the overall preventable harm is preventable. The highest rates of avoidable medication harm occur during prescribing, administering, and monitoring of medication. And this is why this year, 2022, on the 17th September, World Patient Safety Day, today flagging off the National Pharmacovigilance Week in India, medication safety has been selected as the theme for World Patient Safety Day 2022. And the National Pharmacovigilance Week actually is a week-long celebration. All of you have joined us from 1,000+ centers today, whether it is the pharmacovigilance ADR monitoring centers all over the country, 606 centers, or it is the Material Vigilance Program of India, 500+ centers. So with all your support, the campaign has to be further, amplified and escalated so that we can further contribute to medication safety in India and also beyond India. The campaign is envisaged to provide impetus to further, strengthen the WHO Global Patient Safety Challenge, medication without harm. And there have been numerous, advocacy materials, posters, social media messages, etc., which have been developed, which have been shared with all of you already. Dr. Rajiv Raghuvanshi, we are extremely thankful that he has already shared all the WHO advocacy materials, the social media messages with all the ADR monitoring centers and the material vigilance centers for further escalation. This is the strategic framework of the Global Patient Safety Challenge, which has key action areas and for different stakeholders, whether it's the systems strengthening for the health systems, whether it is for the healthcare professionals, the patients, and the public at large. And broadly, the focus or the objective of the World Patient Safety Day is to raise global awareness of high burden of medication-related harm due to medication errors and unsafe practices, to advocate urgent action, to improve medication safety, and further amplify and engage key stakeholders and partners in the efforts to prevent medication errors, to empower patients and families to be actively involved in the safe use of medication, and scale up. Scale up is the word here, implementation of the WHO Global Patient Safety Challenge, the focus this year being on medication without harm. The slogan, as I said, is medication without harm, and the call for action is to, these three words are very critical: know, check, ask. So what is this know, check, ask? I would skip this. How can stakeholders enhance medication safety? Of course, there's a critical role of policymakers and program managers of the healthcare professionals in fostering reporting culture and operationalizing incident reporting and learning systems, provide trainings to all the human resource professionals, who have to be engaged in pharmacovigilance efforts, and also prioritize action in areas where there is, high risk situations such as polypharmacy, transition of care, etc. How can patients at large, take part in the amplification measures of the patient safety? They should be aware of the potential side effects of the medication. And this is where, the no check ask comes in. So what is this no check ask? Before you take your medication, this is an advocacy material developed by WHO, know your medication, check the dose and time, and ask your healthcare professionals. Check that you have the right medicine, you are taking it by the right route, you are taking the right dose, and you are taking at the right time. And ask the healthcare professionals have to ask the patient if they understand before they give the medication. So it is the one on the left is for the patients and the one on the right is for doctors and the healthcare professionals. There are numerous other communication products which have been developed, which are on our website and already shared with you also, social media tools, etc. And on today's day, this is Geneva, and the call is to illuminate your monuments in orange. The orange is the color selected for World Patient Safety Day today, that all monuments all over the world to commemorate the World Patient Safety Day, we may illuminate our monuments in orange color. So a call for all of us to join our efforts and collaboration in achieving medication without harm. And I would end by just playing this few seconds video on No Check Ask, which I highlighted. This is by WHO. Thank you. And I end my presentation here, and it has been a pleasure. And I thank Dr. Rajiv Raghuvanshi for inviting all of us here and getting all of us in the room today, virtually or in person, to flag off the big celebrations of the National Pharmacovigilance Week. Thank you, and Jai Hind.
Thank you, ma'am. Thank you so much for your words. So, ladies and gentlemen, before we proceed to the end of the inauguration, we would like to thank eminent personalities today for their outstanding contribution to the Pharmacovigilance Program of India. We are indeed privileged to have them with us on this auspicious occasion, that is inauguration of Second National Pharmacovigilance Week. So, first of all, we would like to felicitate Dr. V.G. Somani, Drugs Controller General of India, for his kind support to Pharmacovigilance Program of India. Due to his prior commitment, he is unable to join us today. So I would like to request Dr. Rubina Bose, Madam, on behalf of Dr. V.G. Somani, kindly receive his token of appreciation. Please, ma'am. And request Dr. Rajiv to please give this token of appreciation to Madam. Thank you, ma'am. Thank you, sir. We like to felicitate Dr. Urmila Dhate, ex-professor and head SGS Medical College, Mumbai, for her consistent support to the program. She has joined us virtually, and she is currently contributing as a co-chairperson of Signal Review Panel of Pvpi. Can you I request ma'am to
Thank
say
you
a few
so
words.
Oh, I think everybody has said so many things. I want to congratulate everybody actually and really look forward to continuing working with everyone. I must congratulate Dr. Jaiprakash and his team because they're doing such a good work, such good collation of data when they present it to us at the Signal Review, that it becomes much easier for us to work on the information provided. I think what Dr. YK said, that it should not be just a hum, it should be music There has to be conversion of data to information. And that is the most important thing, because it is the only when we have information that we can take informed decisions. And I think that is what we should look forward to. So I want to just thank you, and I want to congratulate you, Dr. Raghuvanshi. I want to congratulate you also for guiding this, as Dr. YK said again, I'm using his words, that you were the Sarathi of this chariot that we have. And I think this is it's important that we have a good leader like you to take us forward. Thank you again. And I do wish that one last word I want to say is that I think that this interaction that we can have with the Pharmacy Council of India is something that we really must look forward to, because these two, the medical system and the pharmacy system in our country, have to come much closer, and we must work together in hospitals. And perhaps the AIMS model, as the president mentioned, the AIMS model can then be replicated in other centers around the country. Thank you very much for this honor and pleasure. It's a pleasure working with you.
Thank you, ma'am. Thank you for your kind words. The next person is Dr. Nilima Shirshagar. Unfortunately, she is not with us right now due to her prior commitment, but no, she just left due to some other commitment. So we would like to felicitate Dr. Nilima Shirshagar, National Chair, ICMR New Delhi, for her continuous support and remarkable guidance to the program. She is currently contributing as a chairperson of Core Training Panel of Pharmacovigilance Program of India. Congratulations to you, ma'am, and thank you for your support. Now, I would like to request Dr. Jayaprakash to please felicitate Dr. Rajiv Singh Raghuvanshi, Secretary cum Scientific Director IPC, for his continuous guidance. Thank you, sir. Thank you. May I now request Dr. Shashi Bhushan, Senior Scientific Officer, IPC, to deliver vote of thanks.
Good afternoon, everyone. It's give me immense pleasure to propose a vote of thanks on the behalf of Pharmacovigilance Program of India. As all of you know that Indian Pharmacopoeia Commission is working as a national coordination center of Pharmacovigilance Program of India, and it have a very robust system for collecting, collating, and analyzing the adverse drug reactions received throughout the country. The main motive of Pvpi is patient safety and to outreach every corner of India. So to accomplish this motive, PPF has started the celebration of the National Pharmacovigilance Week with an aim to provide the awareness about the pharmacovigilance throughout the country. So on this special day, I would like to extend a special thanks to Dr. Kiran Kumar Karlapu, Deputy Secretary, Drug Regulation Section, Ministry of Health and Family Welfare, Government of India, for providing all the support to this program. And in spite of his busy schedules, he accepted our offer and dignify and magnify our event today. So thank you very much, sir. And we are very thankful to Professor YK Gupta, the chairperson, senior review panel, and quality review panel for providing all the technical outputs on the PVI data analysis as well as the PVI expansion plans. We are very thankful to Dr. Rubina Bose, Deputy Drug Controller India, for taking the regulatory actions against the outcome of the PVI and encouraging all the marketing authorization holder to report the ADRs to Pvpi. Thank you, ma'am. We are thankful to Dr. Madhur Gupta, Technical Officer, WHO Country Office, for providing support Pvpi as a WHO Collaboration Center for Pharmacovigilance in Public Health Program and Regulatory Services. We are very thankful to Dr. Montu M. Patel, President, Pharmacy Council of India, for motivating all the pharmacy colleagues to report ADR as well as enroll as the ADR monitoring center under Pvpi. We are thankful to our director, sir, Dr. Rajiv Singh Raghuvanshi, for his dynamic leadership and continuously guiding and motivating us. Thank you very much, sir. Now we are very thankful to Dr. Jayaprakash, Officer in Charge PPI, for their initiative and efforts towards the celebration of National Pharmacovigilance Week. And in last but not the least, we are very thankful to all the participants, my colleagues, and all the partners who are celebrating the National Pharmacovigilance Week, and they make this program feasible and memorable. So by this note, I once again say thanks to all of you for being with us. Thank you.
Thank you, sir. So now with this, we came to end of this our inauguration session. So before we end, we would like to felicitate Dr. Kiran Kumar Karlapu, Deputy Secretary, Drugs Regulation, Ministry of Health and Family Welfare, Government of India, to accept our invitation and spare his time to come. Thank you, sir. Sir, please felicitate Dr. Montu M. Patel, President, Pharmacy Council of India, for accepting our invitation and spare his time. Thank you, sir. Thank you all. Thank you everyone for joining in the inauguration session. I request all the dignitaries and officials to kindly join us for a group photograph at reception.